It is my pleasure to introduce Dr. Jillian Gould, this year's winner of the SRNT Jarvik Russell Early Career Investigator Award. Dr. Jillian Gould is currently an associate professor at the University of Newcastle at Hunter Medical Research Institute in Australia. She is also a general practitioner and tobacco treatment specialist with over 30 years of clinical experience. She earned her PhD in public health in 2015 from James Cook University. She has held multiple prestigious fellowships. She currently holds a National Health and Medical Research Council Fellowship for translating research into practice that is co-funded by the Cancer Institute New South Wales. She has previously been both an NHMRC Early Career Research Fellow and a Cancer Institute New South Wales Early Career Research Fellow. Her research focus is on improving tobacco outcomes for Indigenous Australians, with a special emphasis on pregnant women. As part of this research, Dr. Gould has developed multiple relationships with Aboriginal communities nationally. Each of her nomination letters noted that Dr. Gould excels in building and maintaining relationships with these communities. Her research is really at the forefront of this area, with her publications representing over 50% of publications in this research area on a global level. Dr. Gould's research reach extends well beyond Australia. She was a visiting fellow at the Mayo Clinic, where she collaborated to address tobacco use among Alaska Natives in the United States. And she's working to target tobacco use among Maori women in New Zealand. Her awards are numerous. She has been widely recognized by 7 awards from the Royal Australian College of General Practitioners. In 2017, she was awarded the region's highest honor for an early career researcher, the Hunter Medical Research Institute Award for the Most Outstanding and Gifted Researcher. She has a very impressive portfolio of grant funding. She has received more than $12 million in total grant funding, most of which has been awarded since she joined the University of Newcastle in 2016. Her funding from the NHMRC has been continuous since 2012. She has published 56 journal articles with over 150 total publications, and the majority of these publications are first and last author publications for her. She has presented or chaired at over 140 conference presentations, nationally or internationally. I want to end by just reading this quote from one of her nomination letters that I really loved. Jillian's journey from a clinical GP and tobacco treatment specialist to an exclusive research role has been exceptional. Achieving her PhD recently in her career and achieving a level of funding that many more established researchers only aspire to. She successfully integrates her expertise across several areas to become a leader in her own field, working independently and applying exceptional and innovative solutions to a complex area of need. Please welcome this year's Jarvik Russell Early Career Award winner, Dr. Jillian Gould.
Hello, everyone. I'm very excited to be giving this keynote as the 2021 winner of the Jarvik Russell Award. In this talk, I will tell you a bit about me, my background and motivation, interweaving stories and my research approach. First, my disclosures. I'm funded by the Australian National Health and Medical Research Council and Cancer Institute New South Wales. And my current major work is funded by the Australian Department of Health under the iCIS to Quit project and a few other competitive grants. I don't receive any funding from pharmaceutical or corporate sources and none from tobacco companies, e-cigarette companies, etc. So first of all, I'd like to pay my respects to the traditional owners of the Aboriginal lands where this research is conducted, the Gumbaynggirr Nation, which is in Coffs Harbour, New South Wales. And my talk is respectfully dedicated to the late Associate Professor Marie Gruppetta, who was one of the nominators for my award. So just start with some of my own historical family influences. These are some of my great-grandparents who escaped from anti-Semitism and pogroms in Russia and Poland at the end of the 19th century and early 20th century. My paternal great-grandfather on the right was a felder or lay doctor and herbalist who treated everyone without charge. It was great that they did manage to get out of Europe because my extended family perished in the Holocaust in the 1940s. My tribal affiliation is Levi from both sides of my family, and being here is testimony to my family's resilience and survival. Onto a bit of a lighter note, looking at the influences on my daughter. She had a rather strange upbringing with her mother as a clown. And that picture there with my daughter when she's little with the hat on and following through to when she was 14, we did clown rounds at Grafton Base Hospital. And I ran a clown school at various times. And later on, my daughter became a filmmaker, and her first film was about clown doctors, and they said it was in her genes. So now to the work I do, and a story about babies and cigarettes. They don't mix, basically. When I was pregnant many years ago, and it was just the once, I did everything I could do to make sure my baby would be healthy in the whole sense of the word, such as eating certain foods, taking supplements, having a weekly massage, thinking positive thoughts, and having dance classes to give her rhythm. But now I see this as an enormous privilege to be able to think and feel and act in that way. Many women can't due to poverty, trauma, and lack of knowledge. Moreover, women can be cut off from their traditions and their elders and their wisdom. My mother was a smoker. When she was pregnant, she had an instinct not to smoke, even though it was the early days when harms were just perhaps starting to make the news. Nonetheless, I was born with a congenital heart defect, a heart that was not completely right, and I had surgery just as I turned 1 year old. These days, we know there's a link between some heart defects and smoking. Perhaps my mother didn't quit soon enough or quit completely. She was a highly anxious person, and I witnessed so many times her struggles to quit over the years, and how she, and probably I, suffered multiple effects from her smoking. So many women are not able to give their babies the best start in life. Some women drink, some women smoke tobacco. 15 years ago, I was invited into the work I do with helping others quit smoking. And I have focused my research in the last 5 years on how to help Indigenous women in Australia quit smoking, figuring out where the gaps are and how we can patch up those gaps so that women get all the support they need. And there is a great need, because 44% of Indigenous women in pregnancy smoke in Australia. 6 years ago, we started a project called Our Stories, and I have built a whole body of research and a model of care on the stories that Indigenous women told us about their smoking and their challenges. Women spoke about how little support they received from their family, community, and health professionals for quitting. And sometimes they're immersed in households that smoke, and going smoke-free can be a lonely journey. They, like me, want a strong, healthy baby. In this way, we are not different. What is different is the huge inequity that Indigenous women face, and so much needs to be done on so many levels to redress those inequities and the legacy of colonization. Black lives matter, and Black babies matter. So just a note about my clinical work. I am a GP, and I still worked in refugee health for the last 15 years. I co-founded a refugee clinic in Coffs Harbour, where I live. And I relate to others that struggle with migration, as my family had. And I've had many experiences working in remote areas with diverse populations in Africa, India, and New Zealand. And this all helps me celebrate diversity. And then to tobacco, the early years before my PhD. I have had a decade of experience running quit groups, which I took over from another GP, and it was called Quit for Cats, chronically addicted tobacco smokers. And then in 2005, I was invited to help by our local Aboriginal medical service in Coffs Harbour, Galambilla, to help. They wanted to know what could we do for them, because there was this high prevalence of smoking in Aboriginal populations. And so that was my first experience of co-design and working very closely together with Aboriginal people and the service to create a new program that was targeted called Give Up the Smokes. Then my mainstream quit programs changed a little to something called the Quit Cafe, where I ran a cafe, set up tables and lovely tablecloths and gave people healthy food, and people could drop in to the Quit Cafe for us to help them with their quit journey. And this became later on an Aboriginal Quit Cafe, and you can see on the left the menu for the Quit Cafe. So we divided the possible activities the facilitators could run into entrees, mains, and desserts, depending on what people needed at the time. In 2010, I received some major funding with a local organization I worked with to run a regional program called No Smokes North Coast. And this was really where I started getting some sort of foray into research, because my PhD commenced soon after. But our quit rates were quite good, throughout this period of time. I wasn't really research orientated or designing my studies, but we had quit rates of 26 to 40% at 6 months that were validated. And then later on, during my PhD studies, I ran a quit smoking clinic. So this is just some of the work I did with No Smokes North Coast, and some of you might recognize Dr. Tom Kama, who came and opened our program. And I did run an arts health project for Aboriginal youth in schools. We ran a bit of a competition for that. And we did publish that, and some of the lovely artwork with the children made messages to really target their own families and communities. So on to my PhD, 2012 to 2015. And now I started thinking about, well, what do we need to find out? And my question was, is the message getting through about Indigenous tobacco smoking? And I wanted to focus on childbearing years and pregnancy. The prevalence of smoking in pregnancy about that time was almost 50%. And throughout my PhD, a couple of key points I discovered through a systematic review was that Indigenous people prefer culturally targeted messages, even though there wasn't a lot of evidence from the studies I looked at about whether they would be more successful or not. And a combination of cultural understanding and rigor was important for those messages to be developed. And I was able to make some recommendations for tobacco campaign and health messages. So one of my studies was a national survey of 47 Australian organisations that were making quit smoking messages for Indigenous people. And I did a categorical principal component analysis, which did show two particular factors, which are named cultural understanding and rigour. And under the cultural understanding, the important things seem to be whether the programs or messages were developed from a bottom-up community-based approach, and they had deep features in the message that are related to people's culture, for example, and whether they were pre-tested. And on the rigor side, we had, whether there was a theoretical foundation to inform that development, and whether there was an evaluation of any of that type of research. And it was interesting that the Aboriginal organisations were clustered around cultural understanding, and the government and NGOs were clustered on universities around rigour, but there were very few organizations combining both. So that tree kind of represents artistically how, the roots of this need to be nourished by Indigenous knowledges and Western foundations, and bringing together the two together might give us some best practice approaches with synergy between those organizations. Another part of my PhD research was to validate the risk behavior diagnosis scale among Aboriginal smokers of childbearing age. And that was done by face-to-face interviews at community events. And the RBD scale is based on the extended parallel process model. And we were finding out whether people demonstrated what level of threat versus efficacy they were reporting. And most of the participants demonstrated a high perceived threat from smoking messages, but only half of them had high perceived efficacy. But bringing the threat and the efficacy together was associated significantly with intentions to quit smoking and making smoke-free homes. But if the threat was high and the efficacy was low, what happened was then they lost that association with intentions to quit, but they still were able to maintain smoke-free homes. So we also found out that having been in denial or avoidance, a high fear control, was associated with reduced intentions to quit. So the message coming out of that for me was, threat-based messages, if the efficacy is not there, is just not going to work for this population. So just coming on now to pregnant women, why is it important to help pregnant Indigenous women quit smoking? So we do know that smoking is a major contributor to the Indigenous health gap. So the prevalence has gone down. So in 2009, it was 52% and now 44% in 2018. But improving birth weight is one of the new closing the gap targets. The government is hoping by 2031 to increase the proportion of Aboriginal and Torres Strait Islander women with a healthy birth weight to 91%. It currently sits at about 88%, whereas in the general population, 94% of the general population have a healthy birth weight. So that's really important to get those rates down. And there is limited evidence for what works for Indigenous pregnant smokers. There's been a few randomized controlled trials, and Professor Christy Patton from the Mayo Clinic is very actively engaged in that research. And we've had one previous RCT here in Australia that was led by Sandra Eads, but we still really don't have a picture of what works for pregnant Indigenous smokers to quit. But the key thing is, from my own research, I know that Indigenous women are motivated to quit smoking, and many cut down, but few, only 3 or 4% are quitting completely. And those barriers are quite extensive. They include social norms of smoking and multiple inequities that go back historically. But quitting is worth it, as we know. That there's no question, even when you just look at the economics of it, there's huge gains to be made. And there are, this is some other my research from the Our Stories project, there are multiple opportunities to intervene in smoking along Indigenous women's life course. So, however, being a health professional myself and a GP, I look at all of those and think, well, what about starting with doctors and health professionals? What are we doing? So I looked at that, and through a survey with my PhD student at the time, Dr. Yael Baziv, and we found out that, this is GPs and obstetricians in Australia. Yeah, they were quite good at asking and advising about smoking, but as we came on to different parts of the consultation, there was a slippery slope, and not a lot of women, not enough women, are getting assistance to actually quit, and particularly with helping them with the quit date or providing NRT or even arranging referral. And then we did a systematic review to see, well, what's helping elsewhere. And globally, over 10 countries and 54 studies, and ours was just one of these, almost identical picture happening. It's almost like you feel like you're seeing double here. So this is a global problem that health providers are not giving sufficient help for all aspects of quitting smoking. So what can we do to improve that? So through some other research we found that health providers were saying they need support with communication skills. They need to know more about how to prescribe NRT in pregnancy. They need visual resources for their patients. They need to have cultural competency around Aboriginal settings. And 79% agreed that training would help them improve their care. And we know from a Cochrane review led by my colleague, Kristen Carson, that training in smoking cessation counselling in general is associated with doubling the quit rate in patients. So this was a good place to start. Coming on to just some of my principles for co-development and allyship. I just wanted to mention what I've discovered is my philosophy for an effective approach is to combine principles of co-development with transparency and rigor. So it is very important to build relationships and trust with Aboriginal communities. We need to privilege Indigenous voices, and we need to account for diversity. We have published on a collective and negotiated design that we developed with stakeholders of a way of actually co-developing, and have another of my ex-students, Dr. Michelle Boville, has published that, and how it helps us respect Indigenous knowledge and leadership. We want to communicate transparently and try and publish most of what we do so people can see what was the process we went through in developing those interventions, and having that theory-informed, rigorous approach, using the best design to answer the research question, of course. And one of my favorite is using the behavior change wheel and the associated tools that go with that. But also lately, that kind of brownish circle, which is probably a little hard to read, but it's the Aboriginal social and emotional wellbeing model with 7 different domains, sort of highlighting the importance of connection to mind, body, emotions, family and kin, culture, community, country, and spirit and ancestors. So being able to have that kind of holistic approach. So I've tried to build a solid foundation starting from my experience pre-PhD with training health professionals and co-development, our stories project I talked about, coming up through different studies. So developing an intervention called I Can Quit in Pregnancy that then became SisterQuit, now iSisterQuit on one side, and the other side, another qualitative study called the Mama Study that informed a health app, which I'll talk a little bit more about, and working with multidisciplinary teams. There's a lot of people from a lot of angles that are going into making this research a success, and trying to bring in that sort of artistic elements, video messages, having Aboriginal people hearing those messages from other Aboriginal people. And the picture there is one of my esteemed colleagues, Dr. Marilyn Clark, who's an Aboriginal obstetrician. Just a little bit about the Mama Empower Health app. This is just a bit of a preview of a native app we're developing. It's gone through various iterations. Our first attempt didn't work very well, but this is going to be include smoking cessation, but be a multi-behavioral approach, including social and emotional well-being, and it will kind of mimic a social media platform. So more on that, hopefully, as we get that finished and out there for trial. So just getting back to that sister quit research I mentioned with I Can Quit in Pregnancy, going through different stages, I just want to show you, this has been quite a rapid translation from development to hopefully not in the too far future scale up. So starting this project in 2016 with an initial co-design of the resources and materials in 3 states in Australia and 3 Aboriginal medical services, looking at the suitability of those materials, doing focus groups to get some feedback from people in the community and health professionals, taking them back to the drawing board, revamping them, then going on to phase 2, I Can Quit in Pregnancy, which was a step wedge trial in 6 Aboriginal services in 3 states, and looking at feasibility, acceptability, and some trends for effectiveness. And we did find it was a feasible, acceptable program. And we had about a 14% quit rate, but about 41% women did make a quit attempt. Then we are coming towards the end of a phase 3 randomized control trial. So we're now calling that trial Sister Quit, which was looking at 5 states in Australia, over 20 services, looking at efficacy of the intervention versus usual care. And that's kind of going to be winding up this year. I did receive funding from the government for iSisterQuit. As this was in progress, they wanted me to implement the project in 20 more services, and that's underway. And we're going to be looking at Aboriginal and mainstream services and comparing those contexts. And I'll talk a little bit about the resources going into that later. So that's going to be over the next couple of years. And then we're hoping to get funding for Scale Up. And we're on a short list for a grant that we're keeping our fingers crossed that we might get that funding to go into a full national Scale Up and looking at what is the optimum implementation strategy for Scale Up in this setting. So our current resources for iSisterQuit, we have gone on to online learning, which we're glad we did because of COVID. And this is the learning map from the e-learning resources, the modules, and we're using an ABCD approach: ask, brief, advice, cessation, and D, discussing the psychosocial context of smoking. We will also be integrating our approach into medical software templates, medical practice software, and there'll be some hard copy resources for the health providers and a little booklet for the women, and we're going to supply NRT and a carbon monoxide meter. Now, excitingly, we will have a social media campaign to go along with this, and some of those key messages are going to be things like you're not alone, there's help out there for quitting, NRT can be used in pregnancy. And we're developing this out in 5 different communities, including the Torres Strait Islands, currently to have that campaign launched this year. And looking to the future, I'm hoping to bring technology together really for multi-behavior change in pregnancy. And this will connect the app I've talked about, the e-learning and the software templates, and they'll all connect together into a seamless kind of whole. So that's for the future. Just a few words about international collaborations and just showing some of my collaborators here. I mentioned Professor Patton at the Mayo Clinic, and she introduced me to the Alaska Native Tribal Health Consortium. And for the future, when travel's a bit more open, then we hope to further those collaborations, and also in New Zealand with colleagues there as seen. And then because one of our grants is funded by the Global Alliance for Chronic Disease, I'm very active on several working parties, and I'm co-chair of their lung diseases group. And that gives great opportunities to mix with people from all over the world. It has been a challenging time, and we've had of biblical proportions in Australia with fires, floods, and now COVID-19. And this particularly is challenging in our regional and remote settings. All of you probably saw on the news what happened in 2019 with our bushfire season. We've had cyclones and floods affecting our many sites where we do our research. Indigenous people are quite vulnerable to COVID-19, and some communities shut their boundaries. And of course, during this time, research becomes a lower priority. We have had high turnover of staff on site that facilitate our research, and some services have just had to withdraw. So timeframes kind of become next to impossible. I expect many of you have experienced this, and we've had to put all travel on hold. But we continue nonetheless. This is important work. And what sustains me is remembering my vision and having a flexible approach, being able to have a diversity of skills, being agile in our direction, and some very kind, generous people who help us along the way. And I think it's important to remember those things, to stay strong. And I often think of myself as a bricklayer or bricklayer, a handy woman, it is in my research, because it's important to use whatever's to hand and not get too stuck into any specific methodology, and become more like an artist and a skilled craftsperson in our work, because ultimately it's the strength of the building that matters, not the material we use. And for me, my lifelong journey has been putting together my two hemispheres of the brain, my creative side and my science. And, to do that, I've developed quite a few tools in my kit across not only medicine, but the arts and art therapy. And more recently did a great certificate in media and medicine at Harvard Medical School, which, really brought home to me the importance of storytelling. And these really come under, for me, the umbrella of Indigenous research, having had the opportunity to dip my toes into all of these different aspects, from the arts and the science, and bringing these together, and more to be added. So that was a quick tour through my whole life, I think. But I'd just like to finish by thanking my great team of Indigenous and non-Indigenous staff and PhD students, collaborators, co-investigators, mentors, partnering organizations, funders, and policymakers, and just some of the important funders and policymakers there, just to finish on that note. And thank you so much for listening to me today. And I look forward to having any conversation with people about any of the topics I've covered. Always happy to answer questions. Thank you very much.
Wow, thank you so much, Dr. Jillian Gould. That was excellent. It was really informative for me to get to learn about it, and a research area that's outside of what I normally think about, and I really enjoyed it. I want to remind everybody, Brooke just said it in the chat, but please, if you have questions, drop them in the chat portion so that I can read them out for Dr. Gould, who's live with us, to do a Q&A. So we do have a couple of questions in the chat already. The first one is to tell us a little bit about your work in India.
Thanks for the question. So I've had an association with a place in India called Dera Baba Jamal Singh, which is in the Punjab for over 30 years, and did have an opportunity to do some voluntary work back there in the 80s, which was an eye camp, a free eye camp that where they had, thousands, maybe 3,000 to 5,000 people come through and have eye surgery in the space of a week. So that was a great experience to just see that, charity on a massive scale. So anything more specific about that, I'm happy to
Yeah, drop it in the comment. There's a follow-up to that. That's just great. We also have a question asking whether the interventions are multilingual.
Yes, well, that's a really good question, because there's 300 different language groups in Australia of Indigenous languages. And while, in New South Wales and Queensland, most people do speak English, up in the Northern Territory, English might be somebody's like fourth language. So we have an aspiration in our future phases to incorporate some languages. At the moment, we had thought about that for our media campaign, having some of those health messages in language, but we haven't been able to sort of enter that quite just yet. But we would love to be able to do that and work closely with communities. For a lot of our intervention for Sister Quit and Sister Quit is around health provider training, and most health providers do have their education in English. But I definitely think it would be very exciting to be able to provide people these messages in their own language. It would be so much more salient.
I think this is an interesting question. Do you find that there's reluctance to using NRT in pregnant Indigenous women? And what about the use of varenicline or bupropion?
Yeah, I think that there is a reluctance. I mean, so we're seeing quite low numbers of women are actually offered NRT in pregnancy. And I think there's barriers on both sides. So, I mean, we've done a really good job to tell pregnant women don't take anything in pregnancy. So, people heed that. However, so we do need to have women feel it is safe enough. And health providers similarly need to feel it's safe enough and understand a bit more about the faster metabolism in pregnancy, because we find health providers tend to be a bit cautious. So I don't want, if I give some, I won't give too much. But in fact, you actually need to give higher doses because of the faster nicotine metabolism. So we do need to, that's part of our education training, that we're really emphasizing very practical skills to the health provider on how to prescribe, how to titrate doses, what sort of formats to start with, preferably oral, but going on to combined oral and patch if needed, and how to titrate that to the cravings or strength of urges to smoke, rather than just the number of cigarettes they smoke per day, because that might be quite low. People are trying to cut down. So I think there's a lot of work to do on both sides. And also we need to do a lot of work on access to the medication, because not all of that is subsidized. And it can be really expensive if people have to buy it over the counter.
Great. So I see that we are at time. I think we have about just 1 or 2 more minutes, but then we'll have to wrap up. So we have another question. As part of your co-design for your mHealth interventions, how important has it been that the intervention takes a holistic approach rather than just focusing on smoking?
I think it's crucially important, because when we've talked to women and asked them, well, what's important to you in pregnancy? They just want to feel better. They want to have a better sense of social and emotional well-being, and they want to feel healthy. So it's important to come in on a platform of social and emotional well-being. And we do know that there's a clustering of health risks that go together. It's not just smoking. I think all of us probably know, drinking goes with smoking sometimes. And, all of those other things like physical activity, nutrition can be improved. So, people are willing to look at a kind of multiple health risk behaviors together, but it has to be with the intention to make people feel good and feel better, and know how that's going to actually help improve their pregnancy and birth outcomes.
Great, thank you. So there are other questions in the chat that I don't think we're going to get to, but I'll make sure that I send them to Jillian so she knows what you guys were interested in. But I think I can agree with everybody in the chat who just wants to express congratulations and what an impressive body of work you developed, and what a great presentation that was. So thank you so much, and we'll see you at the next session.
Thank you so much, Tracy, for your introduction and kind words. Thank you.